Yeah, but I mean, it's so interesting. So they talk very specifically recurring infection, infection that goes into different parts of the body, 90 days, 60 days treatment, 30 days IV, oral 60, 30, repeat, both recurring as needed, and this is at the federal level recognized as a benchmark plan. Okay, I'm very excited about this because I don't understand why it's not widely disseminated information and used by groups that are trying to help people have access to care as part of the package of what you need to do and know, and even, just guiding them on how to do it. All right. So let's go back to post-treatment Lyme disease syndrome.
PTLDS, right.
Yeah. So why is it so many people who have chronic, persistent Lyme infection, maybe additional co-infections, they are told, you're not sick, not really. You have post-treatment Lyme disease syndrome. Okay. Where does post-treatment Lyme disease syndrome come from? Okay, since the late 90s, and this coincided basically with government saying, shoot, we do not want to cover this illness. We have so many staff and employees in all these different agencies across the country, even across the globe, that may be exposed to this infection. We will have a very high medical cost.
Right.
And of course, the insurance companies, we don't want to cover this either. Okay, how are we going to go about denying coverage? Well, you can just deny chronic Lyme, but when people clearly have persistent infection and persistent symptoms, you can say, well, let's just deny that it's an infection, and let's reshape this illness as something that is much less than what it truly is, and redefine it and rename it so we can deny care. And that was basically what happened. So they introduced all different types of terms: post-Lyme syndrome, post-treatment Lyme disease syndrome, post-treatment Lyme disease, post-Lyme disease syndrome, and then also just post-Lyme. But what all of these terms had in common was they linked back to the corrupted IDSA Lyme guidelines that said everyone could be treated effectively within 21 to 28 days of oral medication.
Correct, yeah.
For acute Lyme. And as you can see from all the stuff we just discussed, that's not the case, that many insurance companies recognize that, but IDSA members were used specifically, hired at over $500 an hour to deny this. And they wrote guidelines to support the denial. So now we have, since this term was introduced, post-treatment Lyme disease syndrome is the most common use term of it. We have people in the field of Lyme research and medical practitioners who say that they are helping Lyme patients, and researchers who claim that they have Lyme patients' interests at heart, who are using this term, and they say, oh, don't worry, it's only a research term, and it's a very neutral term. We're just using this term to discover what is really causing this problem. And those researchers who are willing to use that term are able to access money from the government through grants, research grants, to study what could possibly be causing all these complications from a treatment, from an infection that was given a very restricted and insufficient treatment. So they're getting a lot of money to perpetuate this terminology.
And I wanted to mention here real fast, Jenna, is that this terminology came from less specific studies that stated, I believe out of Hopkins, that 10 to 20% of Lyme disease patients continued to suffer ongoing symptoms. But I haven't yet found a specific study that states details in studying that particular percentage. Have you?
No, it's what's happened is that basically one person publishes a paper, and then that paper gets cited, and then those two papers get cited, and then those three papers get cited, and it never goes back to any additional evidence of anything. It's one statement that's has poor evidence backing it, and then it's cited and cited, and then all those three papers are cited. Then the next one cites those three papers, then gets cited, and that becomes a fourth. So it's just this round robin of being passed around on these statistics and even the symptoms themselves. I mean, why is it that Medicare insurance page is talking about organ damage and they're just talking about fatigue, when basically everyone who has chronic Lyme actually has far more serious complications than simply fatigue. Fatigue is just one of the symptoms that can recur.
And this is normal fatigue for anybody else listening that isn't familiar with Lyme disease. This is crushing, debilitating, where you can't lift your head off your pillow fatigue or feed yourself at times. This is much different than I need to lay down for a nap. I don't feel, like I have the energy to go on.
No, this is like I can't get out of bed fatigue.
Correct.
Yeah. Okay, so what I did was because we have so many people in our Lyme world who claim to be, supporting Lyme patients and looking out for their interests, who are studying and using the terminology post-treatment Lyme disease, and they claim that it is a neutral term, that it's not harmful. I decided to actually do a deep dive and do a literature research review of all the publications held in the government PubMed website that uses this terminology.
Great detail in how PTLDS interferes with access to covered care, mentioned in federal law. Just throwing that in. It's very important.
Right, no, exactly. Because, I was wondering, why is it, given that we have the Affordable Care Act protecting us, and given that kinetic care recognizes recurring infection, reinfection, and the fact that you could need treatment as it moves into different parts of the body, you need antimicrobial treatment, and they have a far more generous treatment profile than the IDSA, which is extremely restrictive and ignores all of these common complications for late stage chronic Lyme. Right. So what happened is I said, is this a neutral term as certain researchers claim, or is it in fact a biased term? And is it even a research term, or is it a medical term? Because the CDC and the NIH have defined it as a medical term.
That's right.
So any researcher who claims it's a research term is deluding themselves into thinking that it is not also a medical term. And I cannot tell you how many people I've spoken to who have been told, sorry, there's nothing more I can do for you. You have post-treatment Lyme disease syndrome, and there is no treatment for that medical condition.
That just came across my desk about a month ago. I provide resource for patients with the Texas Lyme Alliance and connecting people with physicians. And I was helping a gentleman out of Houston, Texas, who his entire family ended up getting cat scratch fever, Bartonellosis, from 2 cats. He has not been able to get proper care for his Lyme disease and his family's Bartonellosis infection, and even was referred to the Lyme disease expert at Johns Hopkins and was denied care because he had already been treated with antibiotics. And this man told this family, I'm sorry, there's nothing I can do for you because you've already been treated with antibiotics. What a shame. These whole families are being affected and not helped when they have ongoing symptoms after the initial few weeks of antibiotics that is circling as the standard of care, which is not the standard of care under federal law.
Okay, so as I was saying, I did a broad literature review and I found 104 publications in PubMed Gov, which is the library put together by our federal government on all the scientific and medical science publications. And I found 104 publications that used the terms post-Lyme syndrome, post-treatment Lyme disease syndrome, post-treatment Lyme disease, and post-Lyme disease syndrome. I was able to review 103 of the 104 because one of them did not have a text that could be accessed by me. And this is what I discovered. The claim that this is a term that is neutral, it is not a neutral research term. It is actually a medical term being used by both the CDC and the NIH, and they define it in the following way. The CDC does not refer to it as research terminology. The CDC refers to post-treatment Lyme disease syndrome, or PTLDS, as a medical condition and states that PTLDS is not treated with antimicrobials and antibiotics. And then the CDC links PTLDS to reference articles that use the term medically unexplained symptoms.
MUS.
MUS. Now, MUS is a very problematic term. It has been repudiated by the American Psychiatric Association because they found it to be overly broad and exploited. Exploited in that it was being wrongly applied to cases of complex multi-system illness, where instead of seeking biological cause for illness, they basically wrote you off as a hypochondriac.
Can you provide the link you found that on the CDC's website by chance? And if not, we can put it in the notes section of this video.
Yeah, I have all of this referenced.
Okay, I'll provide it after the video for people to be able to click on and see exactly the reference where you're talking about. Thanks.
Yeah, well, you have to look at the references underneath the CDC website. They list a number of references, and MUS is within those references.
Right.
The NIH website makes the following statements regarding PTLDS. Again, they refer to it as a medical condition in patients who have nonspecific symptoms after being treated for Lyme disease and have no evidence of active infection, which of course there's no way to disprove active infection.
The test was studied in, the traditional two-tier test was studied in 2005 and determined that 60% of the people tested with Lyme disease received a false negative. So that's a good point to make here for those watching.
Correct. But basically what they said was that they claim on the NIH website that additional antibiotic therapy is not helpful and can be dangerous. So this is directly in contrast to the federal language under the ACA, recognizing recurring infection and the ongoing need for antimicrobials. The NIH is saying, no, it can be dangerous to get treatment. And then they say there's no benefit from treatment. And then they say it's not supported by evidence. And we all know, of course, that this so-called evidence are these extremely flawed treatment tests that were done and supported by the NIH specifically and CDC to deny, ongoing treatment.
When I dug a little deeper into that, I discovered that they're basing their qualification of ongoing treatment being potentially fatal off of one woman's treatment who actually got an infection from her port.
PIC line.
Yep. Or sorry, her PIC line. It was not the actual, detrimental outcome of extended antibiotic treatment. So we need to distinguish the difference between those two things for the audience.
And the other thing that's very interesting is that they keep the government keeps stats on number of on complications from PIC lines and fatalities from PIC lines, and it's much higher across all these different other disease categories than it has ever been for Lyme, but has never stopped anybody from using a PIC line. Misusing, disinforming, and again, completely contradicting other medical evidence.
They're conflating the outcome of one incident into something that's appearing much bigger when you narrow it down. it's very few incidences and not from extended antimicrobial care.
Exactly. And precisely in that other disease categories have had far more severe and adverse outcomes than Lyme disease for using PICC lines and IV.
Good point, Jenna.
And yet they're not denying the care there. So it's okay. So basically what the CDC, NIH, and IDSA have also done in defining post-treatment Lyme disease syndrome, PTLDS, is that they have excluded all the many objective symptoms. In other words, symptoms that can be proven scientifically. A fever can be proven scientifically. Cognitive decline can be proven through SPECT and MRIs. Brain lesions can be proven through MRIs. All of these complications, they basically, anything that could be objectively proven through diagnostic testing and laboratory testing, they excluded. Suppressed immune function. Many of us are able to get tests showing that our T cells are down, documented. And so they just excluded them from the definition of post-treatment Lyme disease syndrome. They make no mention of them anywhere.
Here going on in my house, I was diagnosed in 2012, just briefly for our audience. I did 4 years of antibiotics and had a port and a PICC line, and tested positive again 6 years later for Borrelia in 2018. So the treatment, ongoing antibiotics, it still doesn't work. It's not curative. So some of their language is correct in that extended antibiotic therapy is ineffective and not curative, but that does not mean that people should be banned from utilizing these treatments, because for some other people, it does put them in remission.
I don't think the term ineffective is accurate. I think the term curative is accurate. It doesn't cure, but it can certainly help people. It can help manage symptoms, and it can put people into remission. And also, to take a point, there are other illnesses that are treated when symptoms arise with antibiotics. And they are also treated long-term with antibiotics. All number of soft tissue infections, tuberculosis can resurge, and of course, the proof that syphilis can be treated and then recur. All of these things. I mean, we have shingles, which is an infection that we get early in life.
Just for the audience, syphilis is a cousin of Lyme disease and can resurface and get additional antibiotic treatment, but Lyme disease cannot.
Right. So it's another spirochetal infection. So I'm just saying, so Lyme is being treated in a very unique and discriminatory fashion, and Lyme patients are being treated in a very unique and discriminatory fashion compared to other diseases that are recurring infections, that staph infections, MRSA, for example. No doubt that you need ongoing care and treatment for MRSA. No doubt you need ongoing care and treatment for syphilis should it recur. No doubt you need ongoing care for tuberculosis that can be treated and then resurface. Okay, you can have a resurgence, but for Lyme, it's not the case. So again, this goes back very much to the cost of the care, which I think set pants on fire in the late 90s when it went into congressional record, that it cost at least $100,000 for treatment. Mm-hmm. And they recognized that it was widespread, it was moving everywhere in the country, there was a great deal of exposure. And if anybody understands vector-borne diseases, for example, I referred to malaria. At one point, I tested for 5 different strains of malaria. Do I have an active case of malaria? No. Did I do prevention for malaria? Yes. But you cannot prevent infection from a small insect if you are in a place in the world where that insect is everywhere. Mm-hmm. And so the prevention basically just knocks back the infection so that you don't get an active case. And nymph ticks and ticks are everywhere. And so it's very hard to avoid infection of Borrelia. Very, very hard. There's a lot of focus on prevention, but again, nymph ticks are not even visible to the eye. You don't even know you've been bitten. So, you know, it's kind of like if you got infected once with malaria and then you showed another case of malaria and they decided not to treat you because you've already been treated once for malaria. I mean, it's crazy. It's absurd. It's absurd. Right. Okay. But the vector-borne diseases are very tricky, particularly ones that are easily transmissible, like malaria and like Borrelia, which is very easily transmissible. Okay. Anyway, so I just wanted to get back to MUS. So the CDC and NIH basically are still saying people who have ongoing symptoms, first of all, only have minor symptoms. They're ignoring the objective symptoms that can be easily quantified and are actually quite severe. And they have redefined this to a mild illness, talking about fatigue as though it's just some fatigue, the average aches and pains of daily life, when in fact that's not the case. But by doing this, they can basically say there's no need for care. And then basically MUS is a psych condition that does not require anything except for maybe some cognitive therapy behavior. So even though you have the American Psychiatric Association repudiating the term,
thank you, yeah,
and they are the specialists in this terminology, they repudiate it, and yet the CDC and the NIH is applying it to this patient group. And they had repudiated it some years ago.
Okay.
Very thoroughly in the DSM-5.
Okay.
Okay, so.
And the DSM-5 is the diagnostics code, just for our audience, for the psychology industry.
Psychiatric illnesses. Psychiatric illnesses. So when so first of all, let's just recognize that post-treatment Lyme disease syndrome and the related terms are not mechanistically neutral research terms.
Okay.
They are medical terms as defined by the CDC and the NIH, is not requiring any care, as occurring after you've been adequately treated on a very short course of antibiotics, and are defined by very simple, moderate, kind of just annoying little symptoms. So every time a researcher says, I'm using this as a research term, they are reinforcing its use as a medical term. These things cannot be divorced from each other, because the researcher in Johns Hopkins is not the one defining the term. It's the CDC and the NIH that define the term. And it's the researcher who is borrowing that term and allowing it to be promoted. Okay. Now, researchers are using it because they get money from the NIH when they use that term in their studies, because the NIH wants to, and the CDC and the government and the insurance companies, they want to perpetuate this denial of care and denial of the seriousness of the disease. So what did I find when I did the review of 103 publications? 70 of the 103 publications exclude infection as a cause for post-treatment Lyme disease syndrome, and they exclude the need for treatment of an infection. 20 of the 103 indicate infection is a possible cause of persistent symptoms, among many other possible causes. Only 13 of the 103 publications focus on antimicrobial and antibiotic treatment for infection that causes the recurring symptoms. Out of the 103, there are very few researchers investigating treatments to address persistent Lyme infection.
Right.
Only 3 of the 103 publications broaden the recurring symptoms to include severe complications such as cardiac and neurological. So what does that tell us? That tells us that the research, oh, and finally, sorry, among the 70 that exclude infection as a possible cause, there is a focus on psychological and psychiatric disorders and post-infectious possible post-infectious autoimmunity
Mm-hmm.
that excludes Lyme infection. Even a form of neuroborreliosis, they say you can have that does not have Lyme infection, but you have neuroborreliosis. So this is not a neutral term. This
Right.
is a term that clearly steers patients into psychiatric treatment for an infection that's been proven to persist. Now, who funds these treatments? Who funds these studies?
Right.
It's mostly US government. It's the National Institutes of Health, the National Institute of Allergy and Infectious Diseases, the National Institute on Drug Abuse, the National Institute of Neurological Disorders and Stroke, the National Institutes of Mental Health, the National Center for Research Resources, and the Department of Energy. And the numbers of Lyme publications regarding PTLDS began to increase rapidly in 2013 and gained more government funding. Prior to 2013, there were only 17 publications.
Wow. Why do you think that is, Jenna?
Whereas 86 articles were published on PubMed between 2013 and 2020. And of these 86, 59 excluded infection.
Just to note the reasons that we're not mentioning negatively people's names, etc., is because this is an interview for educational and informational purposes only, and our views are not related to anyone but our own personally. So it's very important for people to do their own research on the terms and situations that Lyme disease patients are under that are being mentioned today and arrive at their own conclusions. But this is for educational purposes. So I am very grateful that you're bringing up these particular instances and piecing together for the community and organizations outside of the Lyme community to help get patients the necessary care that we need. And I'm sure that we've got a little bit more to discuss, but I just wanted to throw in here that these publications that Jenna has authored and the articles that she's covered, a lot of this information can be found on LinkedIn under Jenna Luche-Thayer. Go ahead, Jenna, with your discussion about your PTLDS study that you did.
So what's also interesting is not just all the exclusion of infection, the fact that this is clearly a very biased term, the fact that it's not serving the patient community, that it's reinforcing an invalid, non-evidence-based push towards psychiatric care for an underlying infection. I also noted that 9 of the studies that ignore infections were actually, that ignore that infection can cause these recurring symptoms, were funded by Lyme nonprofits.
Thank you.
Who advocate on behalf of patients. And I found this very concerning. Why would Lyme nonprofits step in and fund things that are not actually looking at infection when they say they are concerned about chronic Lyme? So I did a deep dive on one of the particular organizations, and I just will give you some of the findings there.
Okay.
I think this is also important.
Yeah, it is.
Yes. So one organization I chose because it's been around for a long time. It has a very high national profile compared to other ones. And I found of the 11 studies that they funded using the term post-treatment Lyme disease syndrome and post-Lyme treatment symptoms, 5 of the 11 focus on psychosomatic and psychiatric disorders in relationship to these symptoms. 5 of the 11. 1 looked at persistent infection and possible drug therapies. 2 looked at autoimmunity as a possible cause. 1 looked at genetic causes, and 1 looked at the Lyme test. So on balance, basically that, you know, the majority of them looked at psychiatric and psychosomatic disorders. This does not really serve the Lyme patient community. If an organization that says they're advocating on behalf of people suffering from persistent infection are funding studies that look at psychosomatic disorders that might cause symptoms.
So,
Okay.
Jenna, do you think that some of this is, first of all, we're all very grateful to all of the Lyme disease advocates and foundations who fight for Lyme patients. This is not to throw anyone under the bus. However, do you think that a Lyme disease foundation who is in fact taking money from Lyme disease patients and their donors on behalf of them would fund a study like this for the purposes of giving too much control maybe to the researcher selected? Why would you think a Lyme disease foundation who is basically in business to support Lyme disease patients would in fact spend Lyme patients' money on funding research around something that could harm patients? Why would you think that?
Well, this goes back to what we looked at, what I looked at, you know, suddenly there was an explosion after 2013 of funding of post-treatment Lyme disease syndrome.
Right.
So clearly what was happening was that the advocacy community was gaining strength and the persistence of the infection was gaining ground. And so there was a pushback, a very organized pushback to redirect and refocus. And what happened is around 2011, some of the Lyme, and 2013, some of the Lyme advocacy groups were actually approached by government to go into research with them. And the same actors, the National Institutes of Health, National Institute of Allergy and Infectious Diseases, National Institute on Drug Abuse, National Institute on Neurological Disorders and Stroke, National Institute of Mental Health, and National Center for Research Resources and Department of Energy basically co-funded research, gave money, big pots of money that these groups might not normally have to do research, and that research was steered towards psychiatric. So they were able to basically very easily deflect a Lyme organization that had a national profile on persistent infection and push them into another line with the promise of partnership and monies. And this is the same thing I would say I observed has happened with researchers. A researcher might start out dedicated to doing something about chronic infection, but then the grant says, hey, we'll give you a grant, but you have to look at psychiatric or autoimmunity or anything but persistent infection.
And I would like to throw in here on my own work. I have started as of this year, just in June legally, our own foundation. And in doing so, what I've discovered is researchers will take money and research whatever you pay them to research. So I think this is an important point that as a foundation, we have to have a strong backbone representing the patient group and not allowing these entities, governmental or beyond, to influence where our money goes for research, because we have to take this control back as foundations to continue to support those that we're supposed to be representing. So I think that's a really important point to make, that we do have the control and we need to continue to keep taking that control back to foster the studies and pay for those research studies that are going to continue to get to the bottom of why patients continue to suffer debilitating symptoms after the initial appropriate care.